Our presentation for today is the endovascular revascularizations of the acute tandem vertebral basilar artery occlusions. And I am Dr. Hui, come from DSA unit from S.I.S Hospital. For disclosures, I don't have any disclosure to disclose. For the background, acute stroke, because of the caused by basilar artery occlusions, it represents for 1% on ischemic stroke and 5% of the stroke resulting from the blood vessel occlusions. And the clinical consequence can be devastating, very severe, with high rates of poor outcomes. And about 40 to 80% of the patients with acute BAO die or remain severely disabled. So despite of the outcome of the acute ischemic stroke due to tandem vertebral basilar artery occlusion were poor, endovascular revascularizations may be a positive approach for acute BAO combined with the vertebral ostium stenosis or occlusions. So today we want to report 6 patients with acute vertebral basilar tandem occlusion by using multi-discipline approaches. So for the material and the methods, we select 6 consecutive patients with acute tandem vertebral basilar artery occlusions in this study, and we will analyze the clinical and the EVT characteristic and functional outcome of the patients. So you can see here the illustration for the clot in the basilar artery and the atherosclerosis in the ostium of the VA artery. And we talk about the procedure. The procedure of the EVT treatment will perform under general anesthesia in all patients, and the access will make through a French femoral artery sheath and AF guiding catheter. We're using most of the cases is the Neuron Max 148 or Fubuki 90 were placed at the proximal subclavian artery, and non-selective angiography performed to evaluate bilateral VA ostia. It's made up to evaluate the both sides of the VA to make it the most comfortable way to access to the basilar artery. And then 048 microwire escalated to the distal brachial artery for anchoring. We use the anchoring for the technique we call another microwire cross the VA lesions, at least V2 segments. So you can see here in the tip, in the pointers is the ostium of the right VA. We can see here the clot here, and the second image it shows we use the anchoring technique. So you can see here the red around is the brachial, like the subclavian artery, and that's the place we will use the anchoring guide wire. And the blue side is the guide wire is come from to the VA artery to V2 segment. And then we use the technique according to Cohen and there are 2 techniques. One is the reverse technique, and the second one is the integrate technique. We use most of the case 6K, we already use the reverse technique. That technique is combined from using the BA occlusions and aspirations. And another one, we will put the stent in the VA ostium later. So you can see here in the reverse technique, the guiding catheter was then sent to distal the V2 segment through the stenosis segment over the partial reinflated balloon. In the 6K, we use 3 techniques to support the escalation process of the guiding catheter. The first of all is to use the attached dilator. The second is partially reinflated or deflated balloon. and the third one using the vertebral 5F catheter. And when the escalation is finished, we will pull out the anchoring microwire. And then using the adapt technique with penumbra aspiration system to eliminate the basilar artery clot. So this is the first of the technique, use the vertebral 5F catheter to support here. The second one, on the left side, we use the attached dilator, and on the right side, we use the partially inflated, deflated balloon. So on the left side, you will see the dilator is escalated through the 0.35 inch wide, and then the AF guiding catheter will push later. And on the right side, you will see we use the balloon, and then the balloon will be inflated to the nominal, and then using it to escalate the guiding catheter. And then after successful recanalization was achieved, the microwire were sent to the V2 segment, and then the guiding catheter was gently pulled back to the proximal subclavian artery and re-anchoring a 14-inch guide wire to distal of the brachial artery. A balloon expandable stent was then implanted at the ostial vertebral artery over the middle guide wire. But before the stenting, we need to use for the patients 300 milligram globularil 1 tab, aspirin 81 for 2 tabs, and we're using the intravenous for unfractionated heparin, which the dose is 50 to 70 UI per kilogram. So here is the summary for the 6 patients we use in the study, and the mean is around 71, gender is females, the onset time is around 5.8, and the GCS, if 4 cases is not coma, the GCS is come from 9 to 12, and 2 patients is less than 9, and 1 patient is just 5. So diagnostics modality is 5 in the MRI and 1 in using the multi-slide CT scan. The access size is using the left VA for 2 patients, 2 cases, and right VA for 4 cases. The mechanical thrombectomy technique we're using only the adapted, so that's mainly directed aspiration of the clot in the basilar artery. For the stenting, we use the stent 4 in 3 cases and stent 4.5 in 3 cases, and the procedure time is around 90 minutes. The recanalization is TICI 3 in 6 cases, and on using the PTCA. And the results is have the 4 patients in the MRS 0 to 2, 1 in MRS 5 and 1 in MRS 6. Complications in malignant cerebral edema is 1 case, and the technique-related complication is the 0. So we talk about the first case. The first case is 67 male admitted due to coma, and the GCS is around 7 point. He has the quadriplegia, is the strength score is over 2/5. The onset time is just 5 hours, and you can see in the left side the diffusions show the acute ischemic stroke, and the right side is we see here is the basilar total occlusions, and we can see here is the DSA come from the ostium of the right VA. So you can see here the right VAs have the occlusion at the ostium, and then we're using on the red around is the ostium of the right VA, and then we use the vertebral technique to escalate the guiding catheter. And you can see here the top right side is the balloon using the technique. And when you use the balloon, on the left side you see the recanalization of the osteum of the right VA, and then we go to the basilar artery. So you can see here there's the occlusion on the proximal side of the basilar artery, and then we use the adapt technique to eliminate the clot. And this is the final results. This is fully TICI 3. And this is the clot images. And this is the CT of the patients 1 day later, 24 hours later. And around three days later, the patient can move his hands good, conscious, and can go to the inpatient department later. So for the second case, this is the 63 male patient admitted due to antemental status. The GCS is 10 points. He has experienced the quadric paralysis is the 3.3/5, and the onset time is just 6 hours. So like the first patient, he has experience on the acute ischemic stroke, and the MRI, it shows no flow in the basilar artery and the VA artery. And then we take the DSA. The DSA is shown on the left VA, no flow. And on the right side, right VA, you see the clot in the right side osteum, and then we use the another vertebral catheter to access to the basilar artery, have the occlusions with the clot. And then we use the adapt technique to recanalize the basilar artery. And in final, we use the balloon expandable stent to put in the osteum of the right VA. And this is the image of the clot. And this is the MRCT of the patient 24 hours later. We show no infections or no hemorrhage. And then the patient can unconscious, can obey the command 2 or 3 days later. And for the third case, this case is 82 female patient admitted to the hospital is coma. The GCS is just 6 points, and quadriplegia with the ET tube, and the onset time is 8. And the MRI, the diffusion is shown in the pons, both sides of the pons, with no flow in the basilar artery. So when we do the DSA, we do the DSA on the bilateral ICA, and then you see on the left side, when we do the DSA on the left side ICA, there is a flow come to the brachial basilar artery, to the posterior circulations. And then we decide to use the left side access, and we use the balloon assisted to the guiding catheter. And when we do the, we escalated the guiding catheter to the V2 segment of the left VA, we do again the adapt technique to recanalize the basilar artery again to the TICI 3. And this is the image of the clot. And then we put the stent in the osteo of the left VA. But 24 hours later, there's the hemorrhage in the pons, both sides. So this case is, in the results is the MRS is 6. So for the conclusions, the most of the patients with acute tandem VBAO admitted to the hospital really late. And when the time is dilated, so the infections, lesions is most expanded over time. So let's say it's very severe. And MRI should be considered as the first line diagnostics imaging modality, because we can see the lesion on the DWI, and we can use the MRI to access to the basilar and the vertebral flow. And the mechanical thrombectomy combined with the VA ostium stenting should be considered as the technique to adopt the best recanalization chance and the good outcome, low complications. And then we want to think about the two guidewise technique has been proved for effective and safe.